The lesion that we inspected earlier with the patient with MAP, and we are proceeding to do the ESD of the anorectal lesion. The proximal gate has been open, and I just want to demonstrate how it's possible to dissect very low down into the anal canal. I have injected a bit of lignocaine because the anal canal can be painful, and you will see that I'll manipulate the dissection device slowly in order to reach the area safely. So just very slowly with the tip of the device, as I don't want to nick any hemorrhoidal plexus. I keep reorientating the cap, and now with my tension to 7 o'clock, so I give good margin to the polyp that is at 12 o'clock. And again, reposition so that then I can have the appropriate tension. And as you can see, the mucosa starts to slowly open. And it's important to have a very clear view so that at any point, as you can see, there is polyp in there. I try to have a en bloc resection as much as possible. This is a patient that is having an ESD with conscious sedation. Again, is a laterally spread lesion very close to the anal canal, so I'm going to inject saline with 2% lignocaine to help with the sensitivity in the squamous mucosae. As you can see, I can open the distal gate just with the tip because I want to avoid any hemorrhoidal plexus. Very slowly. And we can go quite low. Sometimes our colorectal surgical colleagues find challenging to perform tummies when it's so low down, when the polyp is so low down. So we can help with these patients by performing an ESD safely.